I couldn't help notice one thing about your presentation. Only one study, your most recent study was 2006. The rest were from the 90s. Lots of things changed since medical school. All right. You'll see there's a lot of agreement between us. Of course, we all looked at the evidence, but there is definitely some disagreement on some things. After listening to Faraz, I definitely want to change my very last slide. I'll change only one word in it. I'll point that out when I reach it. So flumazenil for benzodiazepine overdose, my recommendation is no, most of the time, especially if it's mixed. All right? Now, pharmacologically, looking at, this is 2016, okay, right, yeah. Pharmacologically speaking, from going back to basic science, it's a competitive binding to the receptor. Essentially, it doesn't have any agonist. Some competitive binders bind and also have agonist, a little bit of agonist action. So it's really flumazenil and naloxone are fantastic pharmacologically. They are the perfect medications, the perfect antidotes we're looking for. The problem is flumazenil is too good for its own good. The problem with flumazenil is not flumazenil, it's what it's going to treat, the benzo. Let's see what the regulators are saying. Leave our decisions, okay? By the way, about conflict of interest, I only have one conflict, which is with Faraz. Otherwise, I have no conflict of interest. So let's look at the regulators. USA, there's a black box warning, all right? So basically what they're saying, flumazenil is associated with seizures. We know that, huh? It's a small complication, right? So what? One seizure every now and then. Somebody might die. So what? Yeah? Seizures are most frequent in benzos for the long term. So if somebody is a chronic user, all right, adult patient who has OD'd and they are a chronic user, you try to treat them with flumazenil to reduce their length of stay in the hospital, so they end up dying. So length of stay is 0. Of course, individualize your patients and be prepared to manage seizures, right? What's the best treatment for seizures? First line? A benzo. So you basically shoot yourself in the foot and then start doing funny things and intubate. Well, intubate to start with. Another 2013, yeah? It's not in the 90s. I don't think I have anything in the 90s. Yeah. How about the other side of the, where's the computer? Okay. UK, let's look at what the BNF says. Standardized thing going through all the politics and regulations. It says it's an unlicensed indication, right? And the licensed indications, like Faraz has mentioned, it's something we have done wrong, basically. Yeah, reversal of sedatives of anesthesia and clinical procedures, reversal in the intensive care, which is not our setting, reversal in the intensive care if drowsiness recurs. And this is important to keep in mind. Flumazenil works for about an hour. And if you have somebody who OD'd, especially, for example, diazepam, it takes a long time. They have a very long half-life. So you can give them flumazenil, they wake up, they sign DAMA, they die somewhere at home. Length of stay, 0. Beautiful. We're legally covered, of course. It doesn't matter, right? There are no members of press in here, right? I can be free speaking. Yeah. 2015. All right. The American Heart Associations. Let's go back to the other side of the point. Yeah. Their most recent recommendations. It's class 3, which basically means looking at their evidence levels. No benefit or benefit is equal to risk. Level B evidence is basically either one randomized controlled trial or one really good non-randomized or a meta-analysis of this. So what they're saying, sorry for the very crowded slide, but this is basically a copy-paste. I'm just putting exactly what they said. So seizures, arrhythmias, hypotension, all right? Without any known contraindications for procedural sedation, you can use it. So basically, if you did the mistake, you can cover it up with flumazenil. If it's somebody else's fault, like the patient's fault, calm down. 2015, right? Yeah. Actually, I'll correct myself. This is 2010. 2015, there was nothing new changing. They even said, we didn't bother to change it. Look at the 2010 guidelines. In fact, naloxone, going back to naloxone, as you mentioned, Now, naloxone has been shown as a perfect antidote, just like flumazenil, but it seems to be doing a good job. Now, there are auto-injectors. It's in the guidelines. There's something there. There's a protocol. There's a drawing with colors. Flumazenil, nothing. Now, let's go back to Europe. In the beginning, I talked about the UK. Now, UK is the Brexit, so I thought I'd better cover all of Europe. So what do they say in resuscitation? Exactly the same stuff. There should be no history or risk of seizures. So when you have an unconscious patient, all right, just make sure that they have no history or risk of seizures. Again, the complication seizures, arrhythmias, hypertension, and withdrawal. And routinely, because you have no history, they're unconscious. They cannot tell you, I took only benzo. All right? So it's not recommended. Now, flumazenil, let's look at I thought, okay, Cochrane, let's look at other people who looked at evidence and meta-analyses and stuff. That was kind of disappointing. I found this. And I even checked it today morning, just in case something happened, It says, stage title, flumazenil for treatment of acute sedative hypnotic drug poisoning. Perfect Cochrane review. It's at title stage. I removed the name of the author, created in 2010. They have not decided yet. I have no idea what they're waiting for. Maybe for us, you're the author? Okay. All right. Let's look at another 2016. I thought, okay, well, they didn't decide. Did anybody else look at the studies and publish them? Yes, there's a very nice meta-analysis. So adverse events associated with flumazenil treatment for management of suspected benzo intoxication. Exactly our title. Perfect stuff. Systematic review and meta-analysis. They looked at a very nicely done couple of them. So significantly increased risk of significant adverse events or adverse events compared to placebo. So if you want a randomized control, all right? And flumazenil should not be used routinely. Poison Center, I was thinking you were going to use this data, but anyway, this is to defend him and then go against him again. All right. So a couple of studies showing Poison Center data saying, you only have one death. Some people get seizures, but we can intubate them. The problem is most of them are probably children. Like I said, they are naive. And voluntary reporting, just keep that. This is a good, useful learning point for this lecture and others. For Poison Center data, you cannot really get safety information from Poison Center data. Yeah? You can know how poisonous something is, but not how safe it is, because there is voluntary reporting. So we have no idea how many patients died because of flumazenil, because never reported, or died at home. This is another learning point before last slide.
Nasaif, you're running out of time.
Sure.
Wrap up.
No, this is not about convincing. This is actually a very important learning point. Some people will tell you, okay, if you're scared, just give a little bit, titrate. Remember, the problem is not the flumazenil, it's the benzo, which we're reversing. And there is no apparent relationship between the dose of flumazenil and the development of seizures. So this is my slide. What I want to change is this. All right? Keep calm or be prepared for seizures. Thank you.
Excellent, really. Really big applause for both of you for really a great debate. I think this was really fun debate. So did we change your minds? No? No? So how many of you will still use flumazenil? Oh, wow, okay. How many of you will not use flumazenil? Ooh. Ooh. Big applause. Thank you very much, guys. Thank you very much. Excellent work. The next team is a team that's going to talk to us about emergency CT abdomen oral contrast, yes or no. I would like to ask Dr. Omar Ghazanfar and Dr. Yasser Saif to come to the chairs, please. Dr. Omar Ghazanfar is an emergency physician from the emergency department at Zayed Military Hospital in the United Arab Emirates. And he's really one of the excellent presenters of emergency medicine at that institute. Dr. Yasser is interestingly one of our fifth-year ER residents who is working in Rashid Hospital Trauma Center for the past 6 years now. He had studied in the Gulf Medical University with expertise at the Al-Mafraq Hospital, Iranian Hospital, and the Gulf Medical University in Ajman as part of his studies. They're going to talk to us about the emergency CT scan, CT abdomen, oral contrast. Should we use it? Should we not use it? So Dr. Omar, you start first.